Thank you for joining LA IVF Dr. Bayrak's webinar tonight. My name is Sarah. I will be your host. Today's topic is Infertility 101. Dr. Bayrak will talk about IVF and treatments. And we want this to be as interactive as possible. So please ask a lot of questions. Dr. Bayrak will answer every single one. And then please type in the question into chat box anytime during the meeting. And remember, you will get 20% off on IVF treatment or egg freezing by asking the questions.
All right. Well, hello, everybody. Welcome to our webinar. Today, we will be talking about infertility treatments, but mainly IVF. And we're also going to touch base on egg freezing a little bit as well. So in terms of IVF treatment, even though it's a broad topic, it does apply to a number of different infertility issues, and it does treat a number of different problems, such as male factor infertility, ovulation problems, declining egg reserve, tubal factor, recurrent pregnancy loss, unexplained infertility. So IVF definitely applies to a lot of different causes of infertility. IVF, in short, is in vitro fertilization. We basically fertilize the eggs in the laboratory and create embryos, and then those embryos are transferred into the uterus to accomplish pregnancy. The process starts with, well, first, obviously, with a consultation with the patients, and then that follows into a workup. That includes male-female workup, whatever is applicable to the situation. And then a follow-up appointment is typically made to review all the test results, and then planning is done, and the treatment is then started. With IVF, typically most patients start birth control pills for a few days or a week or two, depending on their situation. And then an assessment is done with hormone levels and an ultrasound. And if everything looks as expected, making sure there are no cysts, no activities noted in the ovaries, birth control pills are then typically stopped and injections are started. These injections are called FSH preparations. FSH stands for follicle stimulating hormone, which allows us to stimulate the ovaries and mature multiple eggs. This process takes about 7 to 10 days. Patients inject themselves. We teach them how to do the injections. And typically they inject at nights and sometimes in the mornings, depending on which medications are used. And during those 7 to 10 days, patients are typically seen about 3 to 4 times to monitor the response from the ovaries. Once the eggs are ready based on the size, then the patients undergo an egg retrieval procedure, which is done under anesthesia. It's a very low risk procedure. Once the eggs are obtained that same day, sperm is collected, or if there's frozen sperm, then the eggs are fertilized with whichever sperm type, or whether they're fresh collected or frozen is used, and the eggs are then fertilized. And that process takes an overnight kind of a situation where the eggs are then checked the next day, and if they're fertilized, they're called embryos. Those embryos are then cultured for about 5 to 6 days to the final stage called the blastocyst stage. And at that stage, the embryos can be implanted or frozen, or biopsied and frozen in order to perform a test called PGT, pre-implantation genetic testing. And this test allows us to check what we call the karyotype, the chromosome makeup of each embryo, which then tells us whether there are chromosomal problems, whether that embryo is at risk for having a miscarriage, resulting in a miscarriage, screen for Down syndrome, and many other abnormalities, including gender. Then those embryos are identified, and the chromosomally normal embryo is then transferred in a subsequent cycle. So that is IVF, or in vitro fertilization, in the most common form that is being offered today. Let's touch base on egg freezing for a few minutes, and then we'll go into the questions, so that the talk or lecture is short, but rather it's more of an interactive session, so we can answer questions from our participants. Just to remind everyone one more time, if you have any questions, please type in the chat box, and we'll answer them one by one. At the end, please call us tomorrow so we can schedule your complimentary consultation with you, so we can have a more one-on-one session, understand your needs, and talk about options. And all participants do also qualify for a discount for IVF or egg freezing type of a treatment. In terms of egg freezing, the reason for egg freezing is typically for social reasons these days, in order to delay pregnancy or have the option of using their own eggs in the future, where there's a concern that the egg reserve might be declining. In other cases, there may be medications used that can compromise the egg reserve, or cancer treatment, certainly chemotherapy, radiation can lower egg reserve, and that would then necessitate freezing of the eggs for later use. The first part of egg freezing is almost exactly the same as IVF. Typically, the consultation is followed by testing, having another follow-up of identifying issues, checking hormone levels, identifying the egg reserve, which then is followed by planning, where the birth control pills are started with the onset of the period. Another assessment is done, hormone levels are checked again, and then the hormone injections are started. Once again, 7 to 10 days of monitoring, followed by the egg retrieval, and then freezing of the eggs that same day. So we're not fertilizing the eggs, obviously, simply just freezing them that same day. And then when the eggs are in need in the future, then those eggs are then thawed. Then IVF is performed on those eggs by fertilizing them, developing them, possibly testing them with the PGT methodology, and then transferring the healthy or the normal embryos into the uterus. But the first part is almost exactly the same. Egg freezing outcome is very good with today's technology, but never guaranteed, just like any other medical treatment. But if a good number of eggs are obtained, typically about 10 to 15 mature eggs, freezing and thawing goes well, and the sperm quality is good, typically good, high, or excellent quality embryos can be obtained after egg freezing, thawing, fertilization, and embryo creation. And the ultimate success rates, very similar to IVF, really depends on the sperm quality, the egg quality, how many eggs we froze, how we froze and thawed them, and eventually also the status of the uterus and the general health of the person who's carrying the pregnancy. So that's egg freezing and IVF in a nutshell. Obviously, we can talk about this for hours, but in the interest of time and answering questions, I'm going to stop and make this a more interactive session now. So I will go into the chat and answer questions by starting with the first one. So the first question is, let's see. The first question is about, I think, a discount, actually. Yes, everybody will get the 20%. So you don't have to ask a question. As long as you're participating, you will actually get that 20%. So, but if you have any medical questions, we'll be happy to answer them as well. All right. A medical question here is, I would like to know if women with PCOS are better served by using a surrogate versus carrying themselves, given the high risk of miscarriage, premature labor, gestational diabetes, preeclampsia associated with PCOS. So the patients with PCOS, especially in the classic or the typical form, typically would have a higher body mass index. What that means is these patients may have been overweight or obese. Obesity in itself regardless of PCOS, would put a patient at a greater risk category for having preterm labors, increased risk of cesarean, having a big baby, having preterm delivery, high blood pressure, preeclampsia. So there are a number of complications that can happen due to obesity and being overweight. And most patients with PCOS are either overweight or obese. So their risk certainly will be much higher. So one can make an argument where if somebody had multiple complications in the previous pregnancies and they would like to use a surrogate and they have PCOS and their body mass index is very high, I think there would be an argument there that the surrogacy treatment would result in a lower complication rate. But just having PCOS in itself is not an indication for using a surrogate. All right, let's go back to the next question. Is there a weight limit or BMI restriction when doing IVF? The short answer is no, there isn't. But this, I think, ties to the previous question where when the body mass index is high, meaning if there's obesity or if somebody's overweight, the risk of having complications significantly increase. All the complications that were in the question and the ones that I mentioned increase significantly. Also, when we do IVF, we have to implant an embryo. And if somebody is overweight or obese, then the implantation rates tend to be lower. So not only the miscarriage rate is higher and having complication risk is higher during the pregnancy, but also the implantation rate, which is chances of that embryo attaching into the uterus, are also significantly lower just because of obesity and just because of being overweight, which also coexists obviously with a disease called PCOS or polycystic ovary syndrome. All right, let's see. Let's go to the next question. So somebody's asking, what can a male do to improve their sperm health? This is a very common question. Well, in general, keeping a balanced diet goes without saying, exercising, managing stress, keeping a good sleep pattern, at least 6 to 8 hours every night, minimizing or eliminating exposures such as toxic fumes, air pollution, sitting at a desk for a long, prolonged period of time, which would increase the heat around the testicular tissue, which might result in abnormal semen parameters. Getting rid of bad habits like smoking, poor diet, excessive stress, regular or excessive alcohol intake, drug use, cannabis use, smoking or edibles. All of these can actually make the sperm parameters abnormal. If there are hormonal problems, if there are any other organic issues, varicocele or some hormonal problem, obstruction, other exposures on the male side, all of these must be identified and they can then be managed to improve the sperm parameters. Let's go to the next question here. What's the difference between a fresh and a frozen transfer? What's better, or which one is better? A fresh embryo transfer means that somebody undergoes IVF, has an egg retrieval, eggs are aspirated. That's called day 0. And they're fertilized. The next day you check and see and make sure that they're fertilized and you have embryos. And then 2 or 4 days after, meaning on the 3rd or the 5th day of embryo development, those embryos then can immediately be transferred into the uterus. That's called fresh embryo transfer, which used to be the norm, the most common way of transferring embryos, probably about 20 years ago, maybe 15, 20 years ago. And then most recently, the standard is frozen embryo transfer. Both fresh and frozen are standards. They can both be applied to each individual case. If somebody's testing their embryos, then we have to freeze embryos. So if you're doing PGT, then it has to be frozen. If somebody's over or hyperstimulated, meaning you have way too many eggs, 30 eggs, 25 eggs, your estrogen level is really high, you're really uncomfortable, it's better to freeze the embryos and have things cool down, have the hormone levels go back to normal, have the patient feel better, get a period, reset, and then transfer in a subsequent cycle, which would be better. So if somebody's over hyperstimulated or uncomfortable, then freezing the embryos would be much better. But if somebody's just stimulating with low number of eggs, or if they're poor responders, if they're not testing their embryos, then fresh and frozen doesn't matter. It's pretty much the same. So either one can be done, but the most common transfer these days is really frozen transfers because most patients test their embryos for chromosomal problems. All right, let's go to the next question, which is, how many years can eggs be frozen? Indefinitely. There's no expiration date for eggs, sperm, or embryos. As long as they're maintained adequately in the cryotanks, they can be indefinitely frozen or kept. They won't go bad. There's no expiration dates. The next question after that one was, let's see, eggs will freeze in your office or will have some egg bank can freeze. I think the question is, are we freezing and keeping them in our office? Our clinic has 4 locations, just so we all know. We're in San Diego, Chino Hills, Pasadena, and West Los Angeles. All those locations are served by one IVF laboratory, one California licensed tissue bank and surgery center and procedure rooms, which is in our West Los Angeles location. So our tissue bank is also in that location, and it's located within our laboratory. We own our own facility, our own laboratory, so we don't outsource any of those services. So when the eggs, sperm, embryos are frozen, they're kept on the premises in our laboratory, in our tissue bank. So we don't use other banks or other laboratories. We have our own operation, and we pretty much do everything in-house in our own facility. All right. Do you offer natural IVF option with minimal medication? The answer is yes. We offer all types of IVF, including natural cycle IVF, mini IVF, micro IVF, minimal stim IVF, low dose IVF, combination of pills and injections type of an IVF, and also conventional IVF, of course. So we offer all types of IVF depending on the patient's needs. Can the doctor please talk about PCOS and what are the prospects of having normal eggs for retrieval freezing are, somebody said. With polycystic ovary syndrome, most patients tend to have eggs because by definition, polycystic ovary syndrome patients have a lot of eggs that are inside their ovaries at a given time. Now, the quality and whether they're high quality or not is certainly a different question. There's no doubt about that. Women with PCOS, regardless of age, compared to somebody else in their age group, typically have lower egg quality, which is interesting in itself. The hormone levels within the ovary are quite different, as well as circulating hormone levels. And that's probably the reason why egg quality tends to be a little bit lower with polycystic ovary syndrome. That also can reflect into chromosomal makeup, quality, outcome, risk of miscarriage, simply because of PCOS. And that's probably most likely related to the underlying genetic cause of PCOS that is impacting eventually the outcome. Typically, when we freeze eggs or do IVF with PCOS patients, we always have numbers, which is good news because even if most of the eggs or embryos are abnormal, we still tend to find normal ones among them. Let's see here. Do you have any success with patients with Crohn's or ulcerative? Okay, so the core question is, do we have any success or experience with patients with inflammatory intestinal syndromes, such as Crohn's disease or ulcerative colitis? Yes, we do. Actually, just last week, I saw a patient with ulcerative colitis. And over the years, I had a number of patients with such inflammatory disorders. We also treat a lot of women with rheumatoid arthritis, lupus, unexplained connective tissue disorders. We do also work with their rheumatologists and hand in hand manage them. So we certainly have had a number of pregnancies. At certain time points, some of those patients may need to be on steroid therapy or additional treatments, and we coordinate that with their treating physicians as well. The other follow-up question to that from the same person says, what are the side effects of the medications? Are the medications for both male and female? There are side effects of the medications, certainly, because we're giving you hormones. These hormone injections can give you headaches, fatigue, mood swings, hot flashes, sometimes breast tenderness. If you respond really well, and if you have a lot of eggs in your ovaries, they can result in bloating sensation, cramping sometimes. When you are using progesterone, especially if you're pregnant and we're supporting your progesterone, you can have constipation, sometimes gas, pains, or discomfort. Those are some of the most common side effects associated with the medications. In terms of men and women, majority of the time with IVF, women use the medications because they're growing eggs. Men will collect sperm. Having said that, if there are sperm problems and men need hormone treatment with either Clomid or other types of pills or injections like HCG injections, then yes, men will also use injections and somehow experience side effects that may be similar to those where our female patients would actually feel. All right, so let's go to the next question here, which is, what can I take in terms of supplements or diet to help with egg quality? I have low AMH and endometriosis. So when you have low AMH and endometriosis, that obviously relates to declining egg reserve or decreased egg reserve. It's always best to keep a balanced diet, keep a good sleep pattern, exercise regularly, and manage stress. That just goes without saying. And I typically say that to every single patient. Taking vitamins, prenatal vitamins can be helpful. In the past, we used to recommend CoQ10, coenzyme Q10, which is still very popular. It's just that its impact may be marginal. Some people take DHEA. It's a supplement available over the counter. It's a little questionable whether there's really true benefit from that. And then there are many other supplements that you can probably find on the internet or Amazon or through other resources that can be used, have been used, sometimes recommended even by fertility experts. But there's no kind of wonder drug or any kind of perfect supplement that's going to really help with the egg reserve. Egg reserve changes in somebody with endometriosis is due to pathology. That's due to an inflammatory disease that just inflames the ovaries, fallopian tubes, pretty much your entire pelvis. And there's really no good supplement or drug that's going to really reverse that. There are certain medical interventions that can probably slow down the progression of that, but there's no true supplement or kind of wonder drug that's going to all of a sudden change things. What are let's see, are there any additional risks when transferring 2 or more embryos is one of the questions. So majority of the time, we only put back 1 embryo in our clinic to minimize risk of having complications with twins and triplets. So in the past, from 20 years ago, we used to put back 3 to 4 embryos in a fresh cycle, just about 3 days after the embryo creation, because that was just standard almost, just to get patients pregnant. In 2020, as we are conducting this webinar, standard is just 1 embryo, which we have been doing for almost a decade now. Now, that doesn't mean that we only put back 1 embryo and that's it. There's certainly exceptions where we put in 2 embryos. There are sometimes situations where we put in 3 embryos, but those are quite rare. And the standard today, at least in our clinic, is to put back only 1 embryo. The risks would be obviously twins, triplets, and having complications related to that situation or high order multiples. And that's mainly preterm labor. Certainly preeclampsia, high blood pressure, diabetes. There are many other complications related to multiple pregnancies, but the one that we fear the most, the one that can result in devastating complications is preterm labor, especially if it's very early at 23 to 26 weeks. That is a very early delivery, and that can result in severe prematurity. So that's why we would limit the number of embryos we put in. And once again, in our clinic, standard is 1. Almost everybody gets 1. There are certain situations where you can put in 2, understanding that there's a small risk, which would be if the embryo quality is really poor, if the embryos are not tested and they don't look that great. Women above the age of 42, 44 can typically put in multiple embryos because the risk of having triplets, quadruplets, even twins, those risks are very, very low. Not 0, but very, very low. So in those circumstances, certainly the treatment can be customized based on a patient's needs, and more than 1 embryo can then be transferred, certainly. And let's see. All right. Does ovulating late, say cycle day 25, 30, result in a lower quality egg? The short answer is yes and possibly, because if you're ovulating that late, you probably have an ovulation problem. An ovulation problem, especially PCOS, can be associated with lower egg quality, lower embryo quality, poor outcome. If you're ovulating that late, you need to work up. You need to understand why you're not having regular cycles or ovulation on time. Because if you're ovulating on day 30, plus 14 is 44, that means your cycle length is 44 days. That's way too long, obviously. And sometimes you think you're ovulating because you're getting a period somehow, but that can be what we call breakthrough bleeding, which can be confusing, which would mean that actually you didn't ovulate, you just had some hormonal changes, you had a period. So somebody has to do workup, understand, and make sure that they can give you medications to make you ovulate in a reasonable amount of time and not have you wait for 25, 30 days. Plus with that, you won't even know when you need to try because you wouldn't know when you're ovulating clearly. What is a realistic number of egg retrieval rounds someone can go through with low AMH before considering egg donor? That is a highly individualized question in the sense that it all depends on whether the patient's open to using an egg donor, whether there are eggs being created, whether the embryos being created, whether they're developing to the final stage, and whether there's a reasonable number of embryos to work with each IVF cycle. So if somebody has low egg reserve, but they have 4 or 5 eggs, and at the end of the day, they are developing 2 to 3 blastocysts. It's just that they're just either not implanting or they're chromosomally abnormal, but they're able to produce numbers. In that case, it is reasonable to continue, pursue the option, pursue one's own eggs, and do more than 1 IVF cycle. If somebody is not producing eggs or barely any eggs, egg quality is very poor, or embryos just stop developing in culture, they just die, and nothing comes out of it, cycle after cycle, then that person should really and strongly consider using an egg donor, because if you continue with the same approach and pursue using your own eggs, it's probably not going to result in a successful outcome. We never say never, but in general, that will be the case. So there's really no limit in a way. It's not like you do 2 IVF cycles, you have to move on to egg donor. There's no such thing. but you don't want to do numerous cycles and end up with the same outcome or negative outcome, and then keep on doing the same thing, because that's also not reasonable. Egg donation is also a very personal matter. So one has to warm up to the idea, understand the details, understand the genetics before natural conception, understand the genetics between each kid that we have using our eggs or donor eggs, and what are the differences, what are the similarities. Those are very, very important concepts. It's not unusual to have or hear something such as, I want the exact genes to be passed down to my child, and I don't want to use an egg donor. Well, even if you use their own eggs and own sperm from the same dad, same mom, or same sperm donor, same egg donor, it doesn't matter. Each embryo is going to have a unique DNA. Each kid is going to have a unique DNA, even if it's your own eggs and your husband's sperm, or if it's the same egg provider, same sperm provider. It's going to be different. Every single embryo is going to be different. When you use your own eggs, obviously, you're passing down your genes, so there'll be more resemblance. There's no doubt about that. But every egg, when it's fertilized, the embryo that forms will have a unique DNA. So that is in itself important to understand if and when egg donation is considered. Let's go on to our next question here. These are all very good questions. Thanks so much. Let's see here. Can a woman over 45 have their eggs frozen? The short answer is yes, it can be done. It's not like it's a no-no. It's just that there's not enough good data what the outcome would be from those women who freeze their eggs at age 46 or 48, and what comes after that. Obviously, we don't really have a good number of cases or data on that. The outcome, which we can speculate on, would be quite poor, because we know from IVF data that if you're over 46, 47, 48, 50, 52, and if you do IVF, your chances are in the single digits. So your chances are very, very low, which we can then use that information or data and make a comment about egg freezing, which would be probably the same. So the egg freezing would yield a very low pregnancy rate about the age of 46. All right. The other question is, are we going to work with you? I think that would be me, I guess. And the same nurse at each appointment through the process, if we choose the Pasadena location, ? All right. Well, that is a common question. As you know, and as we have mentioned earlier, we have 4 locations. I do not see patients in our San Diego location. My colleague and my partner, Dr. Stephen Brody, MD, PhD, who will be seeing patients in our San Diego location. So if you're coming from San Diego to our clinic, then Dr. Brody will be following you throughout. For egg retrieval and transfer, you will be coming up to Los Angeles, which I will perform personally myself. If you're coming to our West LA or Pasadena location, then you'll be seeing me from start to finish in all of your appointments, including your pregnancy ultrasounds. Our cycles are more in a kind of structured way. So all patients, when I'm in town, do IVF. If I'm on conference or vacation or for another commitment, if I'm out of town and not in the office, we typically do not have any active IVF patients around that time. So every time you will be seeing me, which we believe is better because it provides a better continuity of care. We don't have a system where there's a doctor assigned to each day, where it's like more of a group practice. We don't have that system. So every single time you come in, you see the same physician. After your consultation, you'll be assigned a coordinator, typically that evening. And then within a few days, that coordinator will be contacting you, introducing herself. And that person will take on your case and will stay with you until you graduate from us, which will be when you're pregnant, or if you're freezing your eggs, you will also be graduating for a while. So that person will be your designated coordinator, and you'll have a designated physician from start to finish. Very rarely, I should say extremely rarely, If for some reason I'm not available, there'll be another physician at the same level of education who will be covering me. But for IVF, egg freezing, processes, visits, that would be very rare. Rarely for IUI or insemination treatments or some natural type of an approach that we use once in a while, that can be another physician. But I would say 99% of the time you'll be seeing the same physician, which would be me, and you'll be seeing the same person. All right, let's go to the next question here. If you choose a passive location, it's the same, by the way. I think that was another question. Does low egg count and endometriosis tend to lead to poor egg quality? Yes, because when the quantity is low, the quality is also low. So that is an absolute yes. And then the next question here is, if patient gets eggs genetically tested, can 2 embryos be transferred? The short answer is yes. If the embryos are tested or eggs are tested, yes, 2 embryos can be transferred. That's not a problem. But in general, once again, we recommend transferring 1 embryo because of the risk of having multiples. The next question is, any issues with Moderna booster affecting fertility? No, none of the vaccines affect your fertility at all. They do not decrease it. They also don't increase it. So it doesn't make it better or worse. It has no impact on it. There can be some menstrual changes, some irregularities in certain patients, not with everybody, which eventually resolves and patients go back to their normal cycles. And then we have another question here where it says, I have a very specific question. I'm 25 years old, have hypothyroidism, that's low thyroid function, PCOS, my body's BMI is 18, which is low. That means this person is quite thin. No one in my family has PCOS or had issues. Last ultrasound showed 24 follicles. My doctor said that they're not yet cysts, but they cannot say if they're healthy eggs. So I'm confused. If there are no cysts, then what is going on with me, I guess? That's what you're asking. And you began Synthroid and Metformin, and you still don't get your periods. So you do have an ovulation problem. It sounds like that may or may not be from thyroid function. So you have to normalize your thyroid function first, period. But aside from that, you may not have PCOS. There are many different causes, issues that can result in irregular cycles that can mimic PCOS. You may have something called a hypothalamic ovulation dysfunction. You're quite thin. That may be the issue. So one has to look at your case a little more in detail. If you have hypothalamic dysfunction of ovulation, you should not be using metformin. It won't be effective. If you have PCOS, if you have obesity or insulin resistance, or you have diabetes already, then metformin can be helpful. But short of that, metformin, once again, is not the go-to drug these days. So we don't really use that any longer. So I think it sounds like you may need a little more in-depth evaluation, maybe some assessment. Talk to your doctor about that. Maybe they can submit additional tests to better understand what type of an ovulation dysfunction you have, so it can be treated accordingly. If you need our opinion, just give us a call. We'll do a consultation on you. We'll be happy to review your medical records, check your hormone levels, and I'll be able to tell you what the issue is, and then tell you about the appropriate treatment based on the underlying cause of your ovulation dysfunction, which may or may not be PCOS. It sounds like it is not PCOS on just a quick glance, but you never know. We obviously are not able to give you a sound medical recommendation here over webinar because we just have limited information. But please go ahead and schedule your appointment, and so I can take a look at your case a little more in detail. Next question is, does your clinic have any packages to help with someone who needs to probably do 2 to 4 rounds of egg retrievals due to low egg count? And the answer is yes. We do have a number of different programs, packages, self-pay or other options, loan programs, all of that is available. Our financial person is Stacy Harkins, who's also our office manager. So once we complete your workup, once we complete your consultation even, she can provide you all of those via email. And she typically follows up with a telephone call so she can go over everything item by item. And if you have any questions, you email her, call her. Stacy is very reachable, and she'll be able to review and all these packages in detail and provide the package that is appropriate for your specific case. So if your egg reserve is low, you can do multiple egg retrievals and save some money as opposed to paying for each egg retrieval separately. And then the last 3 questions here are, how does scar tissue affect the implantation and growth of an embryo after having fibroid surgery? So if you have fibroid surgery and your fibroids are removed, sometimes you can have scar tissue inside the endometrial cavity, and that'll be irrelevant. And they can be examined with a procedure called hysteroscopy by placing a camera vaginally into your uterus, which then can show intrauterine adhesions, formerly called Asherman syndrome. That procedure can also allow us to not only diagnose, but treat the problem, which is intrauterine adhesions or scar tissue. Now, there's another type of scar tissue that can happen in the abdominal area after myomectomy or removal of fibroid type of surgery. That means that on the outside of the uterus, just because of the nature of the surgery, tubes and intestine can get stuck into the uterus. This is common. And if that happens, that typically doesn't affect implantation rates or pregnancy itself, but it can affect your anatomy. It can distort the fallopian tubes and their functionality. So that may be a problem. Sometimes it can cause discomfort, pain. Certainly those can be consequences, but the scar tissue that's on the outside of the uterus due to the myomectomy, that can affect a lot of things except implantation. The scar tissue that's inside the endometrium has to be checked, treated, and if it's treated and you're free of adhesions inside, then that would normalize your cavity. Then you should be able to carry a pregnancy. You should not lower your implantation rate or increase the risk of miscarriage. But if you have scar tissue inside your endometrial cavity, yes, implantation rates can be compromised, miscarriage rate can be higher. So that has to be assessed, treated appropriately so you can get the best outcome. Are CBD gummies, no THC, in parentheses, safe to use while trying to get pregnant? Any of those products in whatever form is not recommended to use when you're trying to get pregnant or when you're pregnant. So the short answer is you should not be using them. Does a tilted uterus affect implantation? In itself, a tilted uterus does not affect implantation. It can make the embryo transfer challenging, especially if it's tilted towards the back, especially if it's what we call flexed. Tilted is one thing. If it's flexed, it's a sharper kind of turn when you place the catheter inside at the time of implantation. So that can be challenging. But in itself, retroverted uterus does not lower your implantation rate. There is one exception to that, which is endometriosis. So if you have severe scar tissue, if you have severe recurrent endometriosis, stage 4, women with endometriosis can actually have lower implantation rates. So there's an exception to that answer where if the uterus is retroverted, and that's due to scar tissue, multiple surgeries, possibly where the uterus is just stuck towards the back, and that's why it's tilted, that's why it's retroverted. Yes, that can affect the outcome. But if it's just retroverted because you're born that way, that's your anatomy, it typically does not. And let's see if we have any other questions here. There is another question. It says, does ovarian stimulation help low AMH? So the short answer is yes, because if your AMH is low, that means you have low egg reserve, low response, and injections, IVF would then be treating that problem, obviously. And ovarian stimulation would eventually help that problem. The second question is, do you provide donor eggs as a service? If not, do you have a company you recommend? We do have some in-house egg donors where we can provide those to you. We also work with a number of egg donor agencies where we can get frozen donor eggs, or egg donors who would be willing to come in and donate all the eggs in what we call a fresh cycle. When the ovaries are stimulated, eggs are obtained, and then all of those eggs then would belong to you. So we have both. Whatever you need, we'll be happy to provide that to you, actually. And let me see if we have any other questions here before we come to the end of the session. Thoughts on taking inosol supplement to help people with PCOS. There is some information on this, but it has not become standard of care, unfortunately. Standard of care is still ovulation induction with pills or injections or both, or triggering ovulation with PCOS. And if all of that fails, then you do IVF, which everybody will ovulate on IVF medications, obviously. So it's not standard, but there are many interventions that are coming up that kind of show a promise. And I think, oh, okay, there's just one more question that just came through. If I had an HSG procedure, which is a dye test, hysterosalpingogram, done in 2020, would I get another one done? That is a good, valid question. In most cases, no. And you would just simply do an examination of your uterus if your fallopian tubes are open. If you're at risk over the last 2 years of having tubal disease, then yes, it should be repeated. Or if you had a change in your partner, different partners or high-risk partners were involved, then yes, HSG should be done again. I personally like to look at all the images myself, almost like a radiologist, because I want to see whether the tubes are open, clearly, but also I want to see if they're functional, and whether there's any question of blockage of the tubes. Are they pulled up? Is the end of the tube narrow? Is there hydrosalpinx? Is there toxic fluid accumulating in the fallopian tube, which actually can affect even the outcome of IVF, because it can lower your chances. It can increase the risk of having a miscarriage. So for that reason, I personally like to look at all the images myself, granted that the images are very available. Most hospitals, radiology clinics, departments use electronic health records these days, so it's not like 20 years ago where it would be difficult to get the images or the films. Everything is electronic these days, so all it takes is just getting a CD from the radiology department, sending it over to our clinic so I can review the images, or a link of some kind so we can log in and take a look at these images over the internet or some kind of a portal, and we can review those images. And if the tubes are open from the x-ray from 2020, there's no question mark or anything being abnormal, and you haven't with the same partner, you didn't have any pelvic infections, you didn't have any pelvic surgeries, then you don't have to repeat the HSG. Having said that, you probably have to do some level of uterine evaluation, typically every 6 months. If you're continuing on with medications, treatments, you can have polyps, especially with hormone therapy. And for that, you don't need the x-ray, the full x-ray, because if your tubes are open and you're low risk and everything else is, as I explained to you, then you don't need to repeat it. But if there's any question mark that the tubes may be blocked, then yes, repeating it makes a lot of sense. And that may be the last question, as a matter of fact. Let me check and make sure we have not missed any questions here. Questions that I can answer for you. Go ahead and type them in. Otherwise, I think we're going to wrap things up in the next minute or so. Once again, I just wanted to repeat what Sarah and I have mentioned to you a little bit earlier, which is please call us tomorrow. Our lines are on the emergency service right now. So if you'd like to, please give us a call after 9 a.m. tomorrow morning, Pacific Standard Time, because we're in Los Angeles. So if you're on the East Coast or international patient, our lines will be on and open starting at 9 a.m. tomorrow morning, typically 8:30, but after 9 o'clock, it'll be more guaranteed. Please call and schedule your complimentary consultation with me. We offer video consultations, which we believe are very interactive and efficient. So that would be a free consultation for you. And then if you decide to freeze your eggs or embryos or do IVF or in need for such services, you do get 20% off because you have attended this webinar activity. The only thing is you must sign up for treatment, not necessarily complete, but rather sign up within 3 months of this webinar activity. So we're on the 25th day of April, plus 3 months would be our deadline to qualify for that discount. So I would really encourage you to schedule a consultation so you can start your relationship with us. And thank you so much for attending. I really appreciate all these nice, challenging questions. These are very good, smart questions. Hopefully they were really helpful. Once again, call us so we can have a private one-on-one session for questions that maybe you didn't feel comfortable asking tonight, or other questions that may be coming up, or other things that you want to ask us along with your partner or yourself alone. I'll be happy to answer them. So thank you so much. Hope you all
Thank you, Dr. Bayrak. This has been extremely informative as always. To our audience, thank you for joining us. I typed in our web address and phone number, and also we do have a fertile vitamin address, and you can shop for fertile vitamins. And then remember to sign up to receive your 20% off on your treatments.
All right. Well, thank you so much, and have a lovely evening, everybody. Bye-bye.
Bye.
Bye-bye.